Welcome to the Period Besties podcast with Stasha and Katie. Think about it as chatting with your best friends about all the TMI stuff you've never talked about before with two period coaches who've been helping hormones collectively for over 20 years now. I'm Stasha.
And I'm Katie, and we're pulling back the curtain on what it's like in the world of menstrual coaching. From puberty to menopause and everything in between, we're here to show you how period coaching can save the day. We'll share practical tips and information you can put to immediate use to improve your hormones and happiness.
We're removing the mystery, ending the taboo, and shining a light on just how powerful period coaching can be.
So whether you need period coaching or are considering becoming a period coach yourself, these episodes are going to help you. We'll share stories, coach live on air, and bring smart, savvy guests to share their wisdom too. Let's start today's episode.
What a fantastic conversation with Lara Briden. And I just want to say here on the outset, the number one killer for women is heart disease. And we have a much higher chance of dementia, Alzheimer's, brain issues than men, more than 70%, maybe even. So when you're listening to this episode, I want you to understand how important this is to you, the listener, at an absolutely personal level.
Yes, it was such an enlightening conversation and something that I've been talking to a lot of my clients about recently too, because a lot of my clients are in that perimenopause and menopause stage and noticing their blood work completely shifting and changing with the HDL, the LDL, the triglycerides. So we dive into best ways to prevention in terms of diet, what to avoid, what to focus on. And as always, she just brings her wisdom. And for someone that has the genetic marker of heart disease in my family, it was really comforting listening to her share. And also, okay, I'm doing the things that I'm supposed to be doing to help reduce my risk. So awesome information. Everyone, whether it's in your family history or not, it is the number one killer, unfortunately, and that's been trending for a very long time. This is not new information. This is honestly a must listen to. Yeah, possibly save your life, honestly.
Yeah. So without further ado, listening to Dr. Lara Briden dive in on what we can do, how we can help, how we can prevent things, debunking some myths, and more in this episode. We'll see you inside.
Welcome back, Period Besties, and welcome back, Dr. Lara Briden. We are psyched to have you back on and sharing your wisdom with us. We had such a great conversation last year on ovulation. We're going to go even deeper and talk a little bit about different topics today, but always love your brilliance. So thank you so much for coming back.
Thanks for having me. It's always great to chat with you guys.
Yes, we love having you. We love chatting with you. And we've known each other for years and years. And we actually got to meet in person a long time ago. So that was also so special. Hope to see you in person someday again soon too. So welcome.
Yes, thank you. Yeah, great.
And in the time that we saw each other last, you have a new book out, which is amazing. Your third book.
Yeah, so it's Metabolism Repair for Women. Yes, it's all about metabolic health and insulin balancing. And just, some of these are buzzwords right now, I'm realizing. It seems like my books are always just slightly ahead of the curve, which is lucky.
100%. Yeah. What inspired you to write this book?
Really, it's because metabolic issues are so important fundamentally for prevention of heart disease, for example, which I know we're going to talk about today, but also what's happening with insulin and blood sugar and mitochondrial health. And I know these are all a little bit daunting terms, but they really do have quite a profound impact on women's health as well, particularly around something called polycystic ovary syndrome, but it also plays a big role in perimenopause transition. So just from all my years on the ground with patients, I just know insulin resistance needs to be discussed. So that was my logical next step.
Can you just real quickly run down metabolic health? Because I think for a lot of women, we just think weight loss or gain, and that's the end of it, but it's not even like really touching it.
I know. And the part of the problem is that metabolism is obviously a very broad word. Technically, it can be used to describe any of the 100,000 different biochemical reactions in the body. Obviously, that's not what is actually meant by the term in most conversations. It's primarily about energy, metabolism, how the body extracts energy from food and turns that into body energy, and sort of what's called metabolic flexibility, like how well it is the body's accessing body fat for energy or burning fat versus carbohydrate. And this is all very closely related to a super common hormonal condition called insulin resistance. I started framing it that way. It's a hormonal condition because we all know, okay, underactive thyroid is a hormonal condition, PCOS is a hormonal condition. We know what that means, but I feel like insulin resistance or chronically elevated levels of insulin has not yet earned its place as being something that a hormonal condition that needs to be discussed. And through my lens, a good reason to frame it that way as a hormonal condition is that it's not people's fault. The more common narrative has been, okay, you ate too much and you were just lazy and therefore you gained weight and then you ended up with insulin resistance. That's not how it goes down at all, actually. There's many risk factors. Most of them are beyond people's control that sort of push people into insulin resistance, and then actually a reduced ability to lose weight is a symptom of that, comes later. So common symptoms of insulin resistance are fatigue, feeling hungry all the time. There's like a constant nonstop hunger, usually for carbohydrates, essentially being locked into carbohydrate cravings. And also, weight gain around the middle and high cholesterol. And also the things we're going to talk about today are symptoms of metabolic dysfunction or insulin resistance.
Which sound very much like the symptoms list for perimenopause and PCOS.
Yeah, yes, metabolic health plays a big part in both of those situations. I won't call perimenopause a condition, obviously, because it's a normal life phase. No, you were calling it that, but yes, a difficult perimenopause transition. One of the contributing factors to making it more difficult is if there's an underlying problem with insulin resistance. That can actually then create what one of the scientists, Roberta Brinton, calls like a brain energy crisis. Like the brain cells actually just start not getting enough energy, which is very concerning, which is it contributes to some of the brain fog and neurological symptoms of perimenopause.
How does somebody develop insulin resistance? Does it take a long time, or is it something that happens at a certain age? Like for listeners diving into that topic a little more.
Yeah, let's explore it a little bit more here. And I just wanted to ask you guys as health practitioners and podcasters, and what is your experience with the term insulin resistance? How does that land with you or your listeners? Because I've had various feedback from people that it's, quite a difficult term in some ways. It sort of feels shameful or has stigma around it. Have you had other interviews about it? Or for
me anyway, most of my people just go, what is that? Like I've heard it, but I don't really know what it means. I don't understand what it is. What are the symptoms of it? What do I do about it? They've heard it, but it's not something that they really comprehend.
Yeah. It's more sort of a puzzlement around it. Was that with you too, Katie?
Yes. And they think diabetes.
Yes.
Yeah. Like they're like, oh my goodness. Okay. What am I going to do? I don't want to get diabetes. So that's what I think. There's anytime you hear insulin,
yes,
your brain goes to diabetes automatically versus what we like metabolic health and other factors that play into it.
Yeah, that's a good starting place. And then I will answer your question of how long does it take to develop driving it. It's not synonymous with diabetes, actually. And because a big distinction is that for the early years, potentially early decades of insulin resistance, for most people, blood sugar can be fairly normal, even low at times. So it's not synonymous with high blood sugar. Eventually, insulin resistance can progress into type 2 diabetes or prediabetes and then type 2 diabetes, where blood sugar starts legitimately going above normal. But that's pretty late in the game. So earlier on there, And this is why it's missed, why it's, as I say, one of the most, it is the single most overlooked hormonal condition, because the doctor might go, okay, test screen your blood sugar or your HbA1c, which is a marker of blood sugar, and that's normal, so therefore you're fine. But that a normal blood sugar or HbA1c cannot rule out insulin resistance. It is the situation of chronically elevated levels of insulin, the hormone insulin, which that situation just makes it very difficult for the cells to access the energy they need. And we can explore that a little bit more. But I also just preface it all by saying, obviously, insulin is not a bad hormone. That's one of the other things that happens in the common perception of this condition. So I think, oh, we don't want insulin. We don't want any insulin spikes. But insulin is supposed to go up after a meal. So that's not the problem, actually. It's more the baseline fasting chronically elevated levels. Now, and because people sort of, the term insulin resistance seems a little bit difficult, maybe in some ways, or as you say, confusing because it's mixed up with diabetes. That is why a lot of people, including myself, do start to use more the terms metabolic dysfunction or metabolic inflexibility, which is metabolic inflexibility is essentially just being locked into carb burning, as opposed to our default state is actually supposed to be fat burning. We're supposed to have constant access to our body fat and just drawing on that as energy in between meals, and therefore not getting the hangry, potentially blood sugar crashes. So that's part of it. And the other thing I want to say right now is how so many people got pushed into it. It is, historically, it would have been something that affects older people. I think even historically, there would have been, eventually, as people get into their 60s and 70s, they're going to become less insulin sensitive over time. And there would be people eventually developing fatty liver, but it would have been far less common. I'm talking even 50 years ago, it was far less common. And now, I'm sure you and some of your listeners know that this is an epidemic. And we're now getting, it's almost incomprehensible actually, but we're now getting teenagers with fatty liver. It's a common sign of insulin resistance, pre-diabetes, which is like just gobsmacking. Like that is just crazy. And so that's like really demonstrates how much has changed really since about the 70s or 80s, not through people's fault. It's really not like people just suddenly became like, this makes no sense, right? Like, people have been eating and moving for millennia, and suddenly in the last 50 years, people just started consciously eating too much. That just doesn't make any sense at all. So scientists pretty much unanimously agree something has happened in the environment that has dysregulated the energy systems in the human body at all ages. And it's pushed people into insulin resistance. And it's intergenerational. So it's amplifying every generation. So if someone was pushed into insulin resistance in the 70s or 80s, and then they had kids, those kids are born with they're calibrated to be even more prone to insulin resistance, which is why we're now getting kids with these symptoms. So I have a whole chapter on this. The purpose mainly being to try to dispel shame around it. I think just to try to, as I call it, sort of reality-based, look at what has happened. And it's very depressing in lots of ways. It's very frustrating to think people to realize that the metabolic state they've been pushed into was not their fault. It was from environmental toxins and the food supply.
Do you think that this goes along with the younger and younger menarche, like women getting their periods at a younger and younger age, like samesies?
It's related. I'm sure so it is related including the environmental toxins, because I think most people feel like environmental toxins are probably playing a role in that younger puberty in girls, but it also, environmental toxins are probably, one scientist estimated just exposure to different environmental toxins probably accounts for about 15% of the epidemic of insulin resistance. So yes, so children are calibrated differently in terms of their insulin metabolism. And insulin does regulate female hormone metabolism to some degree. Yes, very, intelligent observation there, Dasha, definitely that's part of it.
Wow, that's a lot to take in, right? When you think about the generational and then the kids, but I like what you're saying about take the stigma away, because I think that sometimes stops people from taking action. So I feel like just knowing that there's other factors going on makes such a huge difference in just the way you view and take care of yourself and your health.
Yeah, it's
Yeah, we have
less
to.
you versus you.
Yeah.
Like you're not battling yourself as when you take away that shame. It's hard to
Yeah.
do that, but when you're like, okay, I need to overcome external factors, it's a little easier to.
Just do the comparison with underactive thyroid, for example, which is a very common hormonal condition. I'm just thinking back to all the hundreds of conversations I've had with patients over the years. And when the women learn, okay, I have a thyroid problem, they don't immediately think, oh, this is my fault. I'm a terrible person because I let myself get a thyroid problem. You just wouldn't, that doesn't, but I have just found that you say, okay, I think you've got this insulin resistance. Oh no, I really dropped the ball. I'm feeling very ashamed of what I've done. And it just, yes, so that's what we're trying to counteract that. We've all collectively, actually, it's the majority of people have been pushed into some degree of insulin resistance. If conservatively, it's probably at least 50% of adults. Yeah, some people got lucky and escaped it, and the people who have escaped it, it's a combination of lots of things, but some of it's genetics, actually. Some people are just a little more resilient, just not as susceptible to, the environmental toxins and food aspects. But the problem is, of course, then it's so easy for those people who just got lucky to think, oh, it's because I did everything right. That's not actually how it works.
So you can't really blame yourself, but then you can't really credit yourself either.
Exactly. Yeah, exactly.
Yeah.
Yeah.
So what's something juicy, like really interesting from the book that you want to share with the audience?
Yeah, obviously my book is from a female perspective, which I think we want to explore a little bit today. So right in chapter 1, I have a section on how men are different. So I always like to frame it that way because I'm a biologist originally. So I do think for 30 some years, I've been working with the premise that female physiology is the normal standard version of physiology, mammal human physiology, and males are quirky and different, and which is just as dumb. It's both. It can go in either direction. Both are obviously normal and default, but yeah, males they're different. Their nervous system is calibrated differently. I think that does mean that they can do potentially stronger interventions. They can power through with fasting and ice plunges. And there's occasionally women who can do that, but I think women's nervous system often doesn't love that. And then the other thing that's different about men is they have this like weirdly just daily, every day the same hormonally, which of course as women we're cyclic beings. And then there's pregnancy and postpartum and perimenopause. And so we have all these different modes or phases. So of course I had to have a whole chapter on exploring how some of those interact with metabolic health. And we can touch on, obviously perimenopause being one of the big ones, and we can definitely talk about that. And then of course, women have to deal with things like hormonal birth control, of which some types worsen metabolic health. And also another sort of fun fact is that men's physiology does actually just respond better to like the old school, like calorie counting, which I'm not a fan of actually. But with female physiology defends against that. Oh, whoa, the horses. No, we can't. If we're going to be eating less, then we've got to make some changes here and conserve that. It's a survival strategy because like women traditionally just couldn't afford to sort of lose fat. So I think just facing that realistically and realizing, and I'm not the only one talking about this. People have known what works for men is not necessarily going to work for women, obviously.
I tried that one time. I was like, okay, I'm going to cut carbs drastically and I'm going to go old school. And I did not sleep for months.
Right. That's
like I just couldn't sleep at all, ever. I was exhausted. I couldn't sleep. I felt worse. And I was like, okay, obviously this is not working. And this was when I was still young, like in my cyclical prime, pre-perimenopause or anything. So it was like, if you were going to try it, that was the time. And it was an absolute failure.
And I've had lots of patients like that. And I will just acknowledge, because there'll be people listening who are like, oh, but I did low carb and felt great. So women can do low carb. Women can do keto and low carb as well, but it just depends on the woman, and I think how it's done to some extent. And I think women might benefit more from cycling on and off that approach. So there's just a lot of nuance to it. And when I was writing this book, there's nuance to everything. So obviously my first book was about periods, and then my second book was about perimenopause, and there's tons of nuance to both of those topics. But when you get to metabolic health, it's wow. There's just so many hormones, part of the symphony of metabolic health is just so many factors, like things like gallbladder and microbiome and mitochondria, circadian rhythm. And it can be a little, for one, I'll just say it's not the kind of system you can micromanage. It's definitely the kind of system where you have to step back, respect the complexity of it. I have a section in the book called Embrace the Complexity. Just realize it's this super complex symphony. And the best way to come about it is to just give your body what it needs. That's the kind of mantra through this book is address your general health to fix your metabolic health. Give your body what it needs. And we can explore some of that today. And giving your body what it needs also does involve sheltering from the modern environment to some extent. We can talk about that. It's about framing it that way rather than restricting, but actually just acknowledging that there's aspects to the modern food supply which have just actively harmed humanity in a intergenerational way. So time to draw a line in the sand and say, yeah, gotta.
I like that you talked about the calorie counting, because I still talk about that with my clients all the time. And I'm like, if you like my toddlers, they're 4 now, eat more than you do. And when I say that, it's shocking to some people, but they're like, but I thought I had to cut so low in order to get results. And even trying to encourage some of my clients to explore eating more is several conversations over months of time, because we've been, I don't even want to, not the word trained, but like from a young age, look at health the same way as men do. So I like that you're sharing that distinction, because I want to preach it from the mountaintops.
Yeah.
Please eat more.
I know what you're describing is the diet culture. Women have been inundated, just battered by it, I would say, for a few generations now. This just constant messaging of you need to eat less. Like it's exhausting. And there is a lot of emotional baggage around that. As in the book, I have a broader chapter on exploring that and dispelling the shame and trying to find a way forward of making changes, not restricting.
Yeah, if you were at all conscious in the skinny jeans, low rise 2000s, you just know that your mind is prepared totally wrong for fat-free craze and all that. It really messed up our idea of healthy.
Yeah, totally. And that's a good segue, because there's an interesting, the word is, there's not a direct correlation between body size and metabolic dysfunction. So there is a lot of individual variation in body size and shape. As we know, that's obvious, but I have a couple sections about that in the book. There's just different, body types, whether that's tapping in a little bit to the old, you guys have heard like the ectomorph, endomorph, mesomorph. Like some people are just muscular and some people are long, lean, and some people are curvy and more, especially for women. There's also some women just have a strong, what's called gynoid shape, like just a lot more bum and thigh fat, which is actually really healthy. That lower body bum fat is actively anti-inflammatory. So every time people hear about how certain types of fat create inflammation, that's true, but that's not bum fat. It's actually working in the other direction. So trying to restrict to diet away a big bum is like just completely in the.
I wish it was all on my bum. It all went right to my belly. Had it gone to my boobs or my bum, I'd been all right, but it went straight to my belly.
And that we can explore that a bit more. That's a bit more in the category of where, something less desirable is taking place.
Let's talk about perimenopause and specific metabolism and metabolic health in that phase. What's going on? Because I feel people say, oh my God, I hit my 40s and everything changed. I hear this all the time. I no longer have a metabolism. My metabolism is so slow. Walk us through what is actually happening in the body versus what might be happening with metabolism.
They're one and the same, of course, because it's
but in terms of kind of that like diet culture metabolism conversation.
One scientific paper described it, and they documented this. During perimenopause, women go through what they call a metabolic upheaval. Quite a profound description. So I would frame it this way. Women of reproductive age have a metabolic superpower from both estradiol, estrogen, and progesterone. I would say progesterone has a mixed reputation in terms of metabolism, but I'm going to say it's actually beneficial. men, younger men, or actually, or at a younger age, men are more vulnerable to insulin resistance than women, because women are sheltered to some extent from estrogen and progesterone. Estrogen, for example, will promote bum fat, but the narrow waist. So estrogen will actually improve insulin sensitivity, so shelter from insulin resistance to some extent. It doesn't mean it's still possible for young women to develop insulin resistance, definitely, but it's less likely. And then in perimenopause, when first progesterone drops away, so that's the first hormone we lose, as that happens, you start getting more kind of androgens, testosterone shining through. In women, too much testosterone above the kind of sweet spot level, excess testosterone will promote insulin resistance and belly fat. And so as progesterone drops away, and then eventually later in perimenopause, when the periods are, absent, then estrogen dropping away causes a redistribution of body fat from the bum to the belly. And by belly, we mean inside the visceral cavity, not just like the bit of rolls of fat on the outside of the belly button. That's quite different. That's still subcutaneous, but like the visceral fat and potentially sometimes fatty liver can be directly downstream from losing a portion of our estrogen. Estrogen never goes to zero. I'll just point out, I've done a few quizzes with my social media followers that I'm asking them, how low do you think estrogen goes? We still actually have quite a bit of estrogen, even later in perimenopause and into menopause, because our cells make it, and the ovaries are still producing actually quite a bit, but obviously less than during our reproductive years. And that is associated with a well-documented shift to insulin resistance that, as I mentioned, actually affects brain energy. Happening alongside that for a lot of women will be Hashimoto's or thyroid issues flaring up in their 40s. I'm sure you've had clients with I always have to try to bring this in. It's another example where men don't really have to think about this. Occasionally you can get a man with autoimmune thyroid, but it's pretty rare. Mostly a female aspect. So when you've got that perfect storm, I think in my second book, I have a Venn diagram, the three things together. So perimenopause, insulin resistance, and Hashimoto's. And if you're in that middle sweet spot, not sweet spot, it's like a not very good place to be, that will be associated with, metabolic problems, high cholesterol, fatty liver, that kind of thing.
We're definitely like Katie's Hashi's, I'm hypo. We're both in perimenopause. So we're right there on that cusp ourselves.
Yeah. I'm sure a lot of your listeners, I'm just like, Hashimoto's is pretty common. Yeah. There was actually just a new paper I shared on social media. I don't know when this is coming out, but in February, I shared a new research paper that surprised no one really who works in this space, that being positive for thyroid antibodies, that's the autoimmune aspect of Hashimoto's, even if thyroid hormone levels are normal, is associated with symptoms, including fatigue and joint pain and brain fog. And so it's, all my books have a section on Hashimoto's, but the new one has quite a big section.
And this actually brings us to a question that we wanted to ask you about, was in that perimenopause state, we see increased risks of heart disease from peri on. So how does perimenopause end up affecting the heart?
Yeah, a lot of it's downstream from the shift to insulin resistance that we just talked about. So one of the downstream consequences of insulin resistance for both men and women is pretty dramatically increased risk of like stroke and heart attack and high cholesterol, and the whole kind of cardiovascular picture. Downstream from insulin resistance is also a higher risk of dementia, which is arguably cardiovascular to some degree for some people. So that's the connection. There's going to be other more nuance in that both estrogen and progesterone had, apart from their metabolism sensitizing, improving aspects, may have direct effects on blood vessels and the endothelium, or the lining of the blood vessels. But I'll give you another example of one of the mechanisms in the many mechanisms of the symphony of metabolic health. But this will probably resonate with your listeners because we're all, as natural health minded people, we're thinking a lot about the gut. And I'm sure your listeners all know what intestinal permeability is, for example. Estrogen, especially during the reproductive years, reduces the risk of intestinal permeability, both by improving microbiome composition and also thickening the mucus lining of the gut. And so when that changes with the later phases of perimenopause and into menopause, there's something called metabolic endotoxemia develops, which is, it sounds like a complicated word, but it's really just bacterial toxins from the gut leaking into the body and increasing cardiovascular risk via their inflammatory properties. So that's just another example. So that already starts to give some ways to manage some of this. So definitely addressing gut health can have lots of downstream benefits for both metabolism and basically weight loss directly, but also cardiovascular health downstream from that. So it always goes back to the gut. Three of the 10 patient stories in my new book are actually about gut health. Yep.
Oh, nice. That's really important. Like, I don't necessarily know that most women realize this, but it's the number one cause of death for women. And women are 70% more likely to have dementia or Alzheimer's than men. So it's not the heart health, blah, blah, blah. Like, this is the number one killer of women, and we're significantly more susceptible to dementia, Alzheimer's, those kinds of things. So it's really important for every woman to go, shoot, what do I need to know? And how do I need to help prevent those things from happening to me or delay them as long as possible?
Absolutely, especially if there's a family history. So I think it can be helpful to look at, have vivid family members who develop dementia. I think it's even higher than that. Women are much more likely to get dementia. And some of it, we know from the emerging research, some of that risk does begin around the perimenopause transition. It's some of the drop in brain energy that happens then. And as you say, like things like breast cancer gets a lot more attention in a way, because I think it's scarier maybe, although as you say, the big picture, actually, heart disease is the number one killer. So yes, it's not a side issue. It's pretty important for
very important, especially like my family history. My grandfather had a 4-way bypass. I have the genetic marker for high cholesterol. My mom does as well. So I've been working with a cardiologist since I had the boys, because interestingly enough, after I went through postpartum, my cholesterol, my LDL dramatically increased. And my endocrinologist was really nervous. She sent me to the cardiologist. I've done like every single test under the sun, and I have the genetic marker for that. So every time I get blood work done, I'm telling the new doctor, I have the genetic marker, but I want to still run all of these tests. This is what my diet looks like. This is what my exercise looks like. But I think that family history piece is so important, because I've been really taking a look at it even before I had children. But I noticed, because I'm a data nerd, I love it, and I can track the past like 15 or 20 years of blood work. And I'm like, whoa, this is dramatically shifting. And interestingly enough, once it went up, no matter what I've been doing, it stays in this range. But I'm going to be 46 in March, nothing's changed since that time right after the postpartum, which is really interesting to me. I'm like, how has nothing shifted?
That is. So I'm not sure whether this would be relevant in your case or not, but just circling back to thyroid, actually anything going on, Hashimoto's, underactive thyroid, can also cause high cholesterol. So just because you mentioned postpartum, if there's like a big jump in cholesterol in a postpartum, I would also be thinking, is thyroid part of that?
Because I was diagnosed with Hashimoto's before I was pregnant. So it was just this cascade of events, which caused my endocrinologist to be like, I'm just passing you along to a cardiologist. Let's just dive deeper, even though I already was. But my mom is 74, and she's been able to really regulate her cholesterol by cutting all sugar out of her diet pretty much.
Which we don't think sugar and cholesterol, like that's not, at least in normal American land, sugar and cholesterol they're not linked together.
This is the paradigm shift that's about to happen. We might be on the cusp of it. I'm not sure where we're at. For 20 years, I've been thinking surely the old paradigm's going to fall down at some point. But the old like saturated fat cholesterol, as like the lipid hypothesis, is probably done and dusted. And that's for the people that would debate that. But the link is, and not necessarily for Katie's mom. I mean, there can be different factors, but like more broadly, one of the big drivers of elevated triglycerides, bad cholesterol, heart disease, one of the big drivers of that is insulin resistance. And so definitely sugar is a big driver. So it's actually pretty well documented in a lot of the scientific literature that high dose fructose, and that will increase cholesterol. And actually the trials on keto diet and low carb, just circle back to those for a minute, they will lower cholesterol there's always going to be sort of variations, and individuals do get high cholesterol going on those diets, but triglycerides will go down. Some of the main sort of cardiovascular markers will, in many cases, reduce on a low sugar, low carb diet. So yeah, good question, Stasha. I think it's time for a shakeup. We're in the middle of it right now, actually. I don't know quite where this is all going to land, and then we'll have to regroup in 5 years and see if the paradigm shifted finally.
Yeah. My mom just constantly gets pushback from her doctors because they're like, it can't be because you're not doing sugar. And she's
Clearly.
It definitely is.
Yeah.
And she's been doing this for over 10 years, if not. Like, my mom's really into health as well. And she does all the research, and she, like, I don't even know what put her on that road, because it was definitely before a lot of other people caught on, but it's definitely changed her health, and something that I obviously am thinking about as well, because we have the same family history.
As I mentioned in the book, I do talk about sheltering from various aspects of the modern food supply. So I talk about sheltering from alcohol. Actually, we can get into that a little bit. Alcohol has had this weird reputation of maybe being heart healthy, but I would say big picture, it's not. That was a lot of wishful thinking. Some of the studies. Sheltering from sugar to more or less degree, and then you always get into the weeds with what about fruit, and it's depending on the individual. Sheltering from certainly added sugar, and then sheltering from ultra processed refined carbs, sheltering from all of the additives, and emulsifiers in particular are potentially on the radar as one of the drivers of metabolic dysfunction, because they promote intestinal permeability. Just circling back to my thing about the role of intestinal permeability, the potential role of emulsifiers, or certain emulsifiers, is one of the things that'll make me pop awake at night sometimes thinking, oh my goodness, what if it was partly that? What if this epidemic of metabolic dysfunction was from this stupid additive that we didn't even have to have? It just makes. And then sheltering from, I'll just mention it at this point, I would say sheltering from polyunsaturated fats to some degree, sheltering from vegetable oils, especially processed vegetable oils. That's another controversial point. That's another part of the sort of paradigm shift that's about to happen, because starting in about the 1970s, 80s, there was this big push to stop eating saturated and go to polyunsaturated. And I would say the writing is on the walls, just through my lens as a biologist, scientist, not an expert in lipid physiology, but still looking at. My take would be there's something bad going on with all this polyunsaturated vegetable oil / seed oil. They do seem to have done something bad to metabolic health, potentially to long-term risk of heart disease in a intergenerational way.
It is a little bit of that. Was it Michael Pollan that said, don't eat foods that your grandparents wouldn't recognize? Like, we wouldn't typically be deep frying things in like a flour oil. The amount of flours you would need to make that oil to use it in a more traditional food is just ridiculous. Like, you would never be able to do that. So it is a little bit of that, at least from what I'm hearing you say, is if you probably couldn't have done that back before the industrial food revolution, then maybe it's not a good idea now, or at least moderation.
Bingo. You just wouldn't have, those foods just wouldn't have, those oils just wouldn't exist. We would be getting small doses of those oils, which the tricky part of it is that omega-6, one of the main ones that sort of in the crosshairs of some researchers thinking what is going on here, it is both potentially problematic at high dose and also at low to moderate dose, an essential nutrient. Right. Obviously, there is nuance, because you can't say it's bad, because it's clearly not, because we need it. So, but normally, yes, historically and prehistorically, it would have been coming from nuts and seeds and grains for some people. And that's great. And also the other oil that has been around for a long time would be olive oil, which is not a polyunsaturated, it's a monounsaturated. So olive oil is the one place where all the different diet camps can meet in the middle. It's like olive oil is healthy. So we've all got that. So it's like it's step one, if you can afford it, because I don't know what it's like in the States, but in New Zealand, the price of olive oil has just gone down.
Costco, baby.
Costco. And you want to make sure it's real olive oil, right? Like I know,
Mhm.
I think in New Zealand they do test it. At least I'm hoping they do. But yeah, I think sometimes you can get adulterated like vegetable oils being labeled, have a little bit of olive oil in there. And I'll just also point out that I don't know what you have in the States, but we have these olive oil spreads, like
Yeah.
margarines, like they're
Mhm.
labeled as olive oil, but they have 20% olive oil and 80%, and I've tried undefined. Like they won't even say what it is because they just want to be able to just keep using the cheapest, nastiest vegetable oil they can get their hands on to make it. People should not be eating those. They just, yeah, hands down, that is just get off anything like that and try to stick with olive oil if you can afford it, butter. Yeah, what other oils do you guys cook with? Avocado oil.
Avocado oil, yeah.
Yeah. I mean, my house is
Coconut.
grass-fed butter.
Yeah.
I make ghee if I'm feeling
Yeah.
particularly kitchen witchy, but yeah, olive oil and coconut oil and
Yeah.
avocado oil. Basically, if it's going to be like roasting something in the oven, it's avocado or coconut. And then if it's a salad or something that I'm just lightly cooking, it's olive oil or butter.
Yeah, same. I know what a big experiment we've been living under, right? With all of the nuances and the new things that come out, and we're like, oh, we'll just change everything drastically. And then now we need to go back and rethink our choices. Is there any other things in terms of, besides avoiding kind of the seed oils and the added sugars, the emulsifiers, what types of food do you recommend women leaning towards to help prevent heart disease and to support that insulin resistance, all of that we've been talking about?
Yeah, and this is where the individuality comes in. I think the way I frame it in the book is step one, get nourished. So you can feel good. So that would mean definitely, I'm sure you've had other experts talk about, like there is a place for protein in the morning, like giving your body the amino acids, the protein it needs, the micronutrients it needs. That's going to go a long way towards promoting satiety, which is this feeling of I've had enough to eat between meals, which is actually crucial for making progress with this. And so the idea is to become fully nourished, and then step two would be shelter from some of these foods, which often does mean learning to cook. The problem is eating whole foods is a bit labor intensive. It can be. And so I do acknowledge that in the book. Not many people don't enjoy cooking. I'm one of them, but it's just, there has to be a way. There's the quick meals, like the one sheet meals or whatever, we just put something in. And in terms of what those like home cooked whole food meals look like exactly, that's where there can be quite a bit of variation. I do make the case for, I think most people are going to benefit from at least some animal product. It doesn't have to be red meat all the time, but like at least something, eggs or fish, or depending on the individual, how they feel with it. I'm very uncomfortable, or well, maybe uncomfortable is not the word. I'm very concerned about any attempt at exclusively plant-based, just because I've seen extremely negative outcomes with patients. But basically, that's one thing. And also just through my lens as an evolutionary biologist, it just doesn't make sense because we're omnivores and there's some key nutrients we need from animal products. But then in terms of beyond that, like the actual ratio of how much of your plate should be, protein versus vegetable versus carbohydrate, there's just quite a bit of variation. I don't know, do you guys have to add to that, or do you have any sort of other
I just think in general, a lot of women are not eating enough food first.
Yes.
So the nourish part, but then fiber. And we know that fiber is so important for the gut. I think we talk about protein all the time, and I still think a lot of women are not eating enough protein.
Yeah.
But then the fiber component also, I think, is getting lost in the amount of how much we need and the variety too, and how that supports our gut. So I just think in general, because they're like, I'm eating so much protein, I don't have enough room for the fiber. I was like, okay, let's like take a closer look then. Like we also need to make sure you're getting some vegetables.
I agree. So yes, vegetables is really important, exactly for fiber and the phytonutrients and the phytosterols and like just so many different things. Also, but we have to also to factor in there. Some people get quite bloaty or don't feel great with vegetables, which is, I talk about that in the book actually. So if that's happening, then that's usually a sign of SIBO or small intestinal bacterial overgrowth. And then some treatment for that can then help to be able to eat those things. It's a bit of interesting interaction between, so people probably heard of a low FODMAP diet being helpful for IBS or SIBO. Would your listeners know the term? Yeah, small intestinal bacterial overgrowth. But FODMAPs are fiber, right? So there's tons of people might have actually been prescribed a low fiber diet to try to help with gut. So there's a little bit of nuance there. And actually, in terms of protein, I would say it's not even just it's definitely not the more the better, because I feel like there's an upper limit, I think. And there is a place for kind of strategically lower protein, especially in the evening. I can talk about that a little bit for certain body types. Like a vegetarian kind of low protein dinner can actually hormonally be quite metabolically good. I think it's, for a lot of women, it's more about the timing of the proteins. So I think I'm a big fan of protein by 10 a.m. It could be earlier if women are hungry by 8 or 7, then sure. But at least, even if people who are attempting some kind of intermittent fasting, I would say give your nervous system, give your circadian rhythm the signal of protein by 10, because it actually helps to entrain circadian rhythm and calm the nervous system. And yeah, so I don't want people, fasting too long and then all the protein in one hit later in the day, because that's probably not ideal.
Yeah.
Yeah, I think one of my favorite things that I've recommended with clients that I had seen help the most is the bone broth with squash. Just, it's so gut healing. It gets into that deeper intestine. It's just one of those things that I find that even when I have clients that have really bad digestive issues, cooked squashes seem to be okay. So it was always like, you know what, if all else fails, let's have bone broth with your meat of choice as a protein, and squashes would be summer, winter, whatever. Let's just start there, because it seems to be helpful for repairing that gut lining, for helping to get that nourishment in deeper, and helping to, and then a little sauerkraut. So a little GAPS diety, a little bit of that sauerkraut juice if you can't quite get to the actual sauerkraut itself, but having that like probiotic that travels deeper into the intestine. And that one seems to be very soothing. And I have not yet had a client who was like, no, that's making me bloaty and I hate it. So it seems to be pretty good universally, at least on my end.
I'm a chicken soup for breakfast kind of woman. Yeah. So that's you too. Yeah. That's my favorite. It's my favorite breakfast. And certainly there are cultures around the world. That's what is considered breakfast food.
I like
and I did talk about
easy.
Go ahead.
You were saying like not cooking and one sheet meals and stuff. That's what I like about it, is you just put the crock pot up. You've got bone broth in there, and you just throw some veggies in at night, and you wake up in the morning and it's ready to go. And I'm like, there's nothing I like more than something that cooks when I'm not there and is just ready for when I am.
I love it. I have to use that quote from Stasha. Yeah, food that cooks when I'm not involved. I don't like cooks itself, basically, in the oven or in the crock pot or
I love it. What about maybe another controversial topic, but hormone replacement therapy with perimenopause, menopause, and heart disease? What is the correlation there? And what are your thoughts on all of that? Because I definitely think, especially in the past 2-3 years, the conversation on social media with hormones has definitely increased drastically. So just want to talk about that.
Yeah, you think? It's gotten a little crazy out there.
Yeah. Kidding. I know, I was being kind.
Katie just did the understatement of the interview. It's like but a little bit of enthusiasm around hormone therapy. I actually I just don't even know where to begin. Okay. Yes, I guess step one is it's pretty clear that estrogen therapy can mitigate some of this shift to insulin resistance and heart disease. I think that's clear. I think, but again, there's nuance underneath that. It doesn't mean that every single person needs it. I guess one way to think about it, even in my second book, I talked about this. I talked about basically estrogen is going to mitigate or reduce to some degree the shift to insulin resistance. So I actually think if they were to do these long-term studies, if they were to find a way to sort the data so that you're looking at women with insulin resistance versus women with good insulin sensitivity, I think you'd find it's actually the women with insulin resistance who might get a heart disease reduction from estrogen therapy. So that'd be interesting in the data to see that as a mechanism. But then of course we've got what's the other parts of the hormone therapy. So certain progestins, especially the androgenic or testosterone-like ones, are not friendly to metabolic health, basically. So that's a factor. And they're not friendly to breasts either. There's another whole side of things. But whereas progesterone or oral micronized progesterone, natural body identical progesterone, which is a lot more common now, even mainstream prescriptions, which is great, is I would argue metabolically beneficial. It's also potentially, some people would at least frame it as metabolically neutral. It gets a little nuanced because progesterone technically does reduce insulin sensitivity a little bit. That's one of its jobs, but it has so many other metabolic benefits that I think it has a net benefit. So that's it, is that. And then there's what if testosterone's thrown into the mix, then that gets even more complicated. Like a little bit of testosterone in combination with estrogen and real progesterone could be beneficial, but too much testosterone in any context from any situation does promote insulin resistance and heart disease in women. So I think women just need to be careful taking testosterone out. In my last two books, I do talk about the shift to what's called relative androgen or testosterone dominance of perimenopause and menopause. It's not that testosterone goes up really. It's in both sexes, testosterone is on a slow decline through life, a linear decline. It doesn't drop dramatically at menopause or anything. It just keeps going down. But part of what happens is, when estrogen and progesterone shines through, and that's why women get more facial hair. They get the redistribution to more of a male body shape with the kind of thickening of the waist, losing the bum, and then that sort of shift to insulin resistance. So that was a long-winded way to, should women take estrogen therapy? I guess the short answer would be maybe, especially later in the, not in the early phases of perimenopause when periods are heavy. I just said a takeaway for anyone. If periods are heavy and breasts are really sore, estrogen is high. It has been high. Estrogen is always fluctuating, going up and down. And what happens in the early phases of perimenopause, it starts going up to 3 times higher than it ever was before, and then crashing down as it normally does before the period. And that deeply dropping estrogen can produce symptoms. So there's different ways to shelter from that. Maybe even taking a little bit of estrogen therapy during that estrogen trough, but being on long-term, I've never seen that an estrogen prescription can remedy the symptoms of that earlier high estrogen phases of perimenopause, but there's a place for it later. And how does that fit with where you guys are thinking about it?
Yeah, I feel like that's what we've been talking about, just the two of us and then people on the podcast too. I guess my question always is, and I know this might be complicated to answer, but what comes first? What do you think out of everything that we've been talking about to prevent heart disease? What avenue would you recommend people start first? Depending on age, would they start with hormone replacement therapy, or would working on the diet first? What would be the number one thing, or does that depend on where they are in that cycle of perimenopause and menopause? Because I think that's where it gets a little overwhelming. Does it depend on my age? Does it depend on my periods? Should I just jump to the hormones so that I can just protect my heart just in case?
Yeah, I know. So I guess depending on what we mean by what comes first. So I'll just say in terms of like big picture, zoomed out, what is driving a lot of the problems is insulin resistance. It comes first in terms of it's at the base of the pyramid. Like so just giving a quick framing, like I talk about this in both my last two books, like the transition to menopause is normal. Like definitely it's not new. I know many individuals used to die in childhood and not make it. Like on average, the average lifespan was 40 something, but there were always individuals who got through to 80. We know that for a fact. And we're pretty confident that menopause evolved, actually, that probably humans evolved a longer human lifespan to select for women living 30 years past menopause. So it's a normal thing to do, I think. And in many cultures in the world, especially the more traditional modern day forager people like the Hadza, they're happy about menopause. They don't have symptoms from it. They love it. You get to stop making babies then and just move on to other things. And so just framing it that way so that, just to point out, perimenopause is not inherently symptom or disease promoting, although in our modern world it is, because of this. It's a recalibration that's happening. Anytime there's a recalibration or I don't want to get too wordy here, but to go back, the insulin resistance is a big driver of why perimenopause is so difficult and problematic for a lot of women in our modern world. And again, through no fault of their own. So from that perspective, in correcting metabolic health or working on it, sheltering, all the things we've been talking about is high priority. But in terms of what do you do first to feel better, I guess the other way to rank what is first, for my patients, it would be what is most distressing. If women are just really not functioning, like just need some assistance just to get going and be able to make some of the other changes, then I would come in with magnesium, number one, something easy, circadian rhythm, just like easy, these are the easy wins I talk about in the book, just to start to feel a bit better. And hormone therapy could be in those kind of initial first weeks as a tool to start sleeping and feel a bit better, to be able to make the other changes. I guess it could come early in the process for that. And I, especially earlier in perimenopause, I would often start with progesterone, because it's interesting how many people I've talked to who, I started HRT, even so the old term is HRT. I said the more modern term is hormone therapy, and I felt amazing. Like I slept like a baby the first night I took it. It's like, that's the progesterone. If prometrium is in the States, or another version of the body identical progesterone, if that was part of the prescription and your first relief is that you slept well, that's progesterone. Estrogen also has benefits, but progesterone is probably the fastest, one that kicks in the fastest.
Yeah, I went in the first ovulation I skipped. So clearly in perimenopause, skipped ovulation, official. I went in and to Planned Parenthood actually and talked to them about progesterone. And turns out with endometriosis, she's, oh, you can have progesterone for endo. Like I can just write you that prescription today. So I walked away from that with the progesterone prescription. And then I went back and was like, I don't know that I want to add in estrogen down the line, because I'm looking forward to menopause for obvious reasons. As much as I wish I had those years back, it is what it is. So I'm wholeheartedly enjoying my progesterone supplement, but I don't know that I will end up adding in that estrogen, because that promotes the endo growth and all that stuff. So I really am looking forward to having my periods cease and not extending them with a hormone replacement therapy or increasing the estrogen. Also, my family has the BRCA gene. My mom, and I think I haven't done the testing yet, but everyone got breast cancer in their 30s. If you didn't get breast cancer in your 30s, you didn't get it at all. So all the women in my family. So it was like one of those things where I, like, when I was looking at HRT for myself personally, I was just thinking, I'm going to avoid the estrogen. I think I'm just going to stick with the progesterone. It's great. I can sleep. Like you said, I can sleep again. It's really nice. And then I think I'll just stick with the progesterone postmenopausally and avoid the estrogen bit personally.
That's great. Sure. I might just respond to that. Yes, it is totally valid strategy to use progesterone only. That some of that we have now at least one paper about that from Geraldine Pryor. Probably knows she's a close colleague of mine. She's an endocrinologist in Vancouver. She'd be a great guest. She's a busy lady, but she did a clinical trial of progesterone for both perimenopause and the early years of menopause, and it can work really well. And Geraldine, she's not anti-estrogen. She also does acknowledge that some women feel better on it. So there can be, even she would say there's a place for it, but she also frames the low stable estrogen of menopause as like nature's gift to women. Like a lot of women feel a lot better without that, with lower levels of estradiol. And I'll just point out again, the body makes it, the brain cells make their own estradiol, and ovaries are still putting out some estradiol, and sort of being at that stable low estrogen state is very different from being in that up and down estrogen where you're exactly going through an estrogen withdrawal every month. That all stops. There's this beautiful quote from Geraldine Pryor. Women need to know that the turbulent time of perimenopause ends in a kinder and calmer phase of life called menopause. And that part of that kinder and calmer phase is the stable low estrogen. So there are, certain people who've had endometriosis or other things going on actually just arrive at menopause and actually love the kind of stable low estrogen. So yes, that's also a really good thing to bring in here.
That's one of my best friends. She's 10 years older than me. She also has endometriosis, and she'll be like, girl, you can't wait till you get here. It's so much better.
Yeah, exactly.
My cheerleading squad for the future. Yeah. Actually, you're one of those people who are just absolutely on the cutting edge of studies. And I'm going to just absolutely hijack you a moment for a personal request. But anything new or interesting in the land of endometriosis research you'd care to share?
Yeah, it just, again, it's a area where I think there's going to be a paradigm shift soon. It's about to crack open. I think I don't know when it'll come out, but I do these little solo podcast episodes where I just talk for 15 minutes. My next one I've been promising for half a year is about endometriosis. So there are, I'll just say, because there's a whole bacterial contamination hypothesis, which I've been following for about 10
found
years.
that fascinating.
Yeah, so there's some new research around that. It's a lot to do with the gut microbiome and bacteria in the pelvis itself, bacterial toxins in the pelvis, and how the immune system gets very upset about that. So there's that aspect. But there's also, I don't know how to phrase this properly, like the hyper focus on the lesions that we've had for the past century is actually breaking down. And there does seem to be evidence that in both directions, there could be quite a lot of inflammation and pain and even fertility problems, even when the lesions aren't immediately apparent. And then vice versa, especially the different types of lesions. There's like some certain lesions, yes, are going to be pathological always, but some of the more superficial lesions, there may be disconcerting evidence that they actually may just be a kind of normal physiological thing that comes and goes, and we shouldn't get too fixated. Because that could be women who have no symptoms at all, no problems with fertility, like totally fine. In fact, they know this from research. If you, like one kind of concerning statistic is that if there's a woman with pelvic pain or infertility or some kind of indication, they go in and have a look with surgery, about 45% of the time there's endometriosis lesions. At the same time, women who have no symptoms, no problems, have surgery probably for tubal ligation. That's usually the reason. They go in and about 45% of the time there's lesions there. So it does start to mean, okay, wait, what are we talking about here? So that gives a little preview. I don't know, what's your response to that? It's good to talk to you guys about it before I release my podcast to the world. Had you heard that before? Or this?
Oh yeah, I remember reading a handful of years ago. I know time has no meaning anymore in our modern days, but I remember reading that the stage of endometriosis and your symptoms have zero correlation. You can have stage 4 endo and zero symptoms. You can have undetectable micro endometriosis, I believe is what they called it, and have horrific symptoms. So I know that one of the things that had been discussed was switching the categorization of endometriosis because it had so little correlation with symptoms and fertility and those kinds of issues.
My understanding is the new, rather than the stage 1 to 1 to 4, should look whether it's just superficial versus deep infiltrating versus endometriomas or the chocolate cysts. So those are kind of, and the superficial lesions are really questionable as to what that even means. But the deep infiltrating and the endometriomas are more clearly correlated with symptoms. So yeah, that's where it's a great question. It's obviously required. It would deserve its own episode. We can maybe meet next year and do a endometriosis. See where everything's at.
Well, I had a client who didn't know she had endometriosis until she had to have an emergency C-section.
Yeah. And then they just observed it. This is the question, like for people what is even the significance of that? There's another expert, I do offer her name very often if she's not already on your radar. Dr. Peta Wright is a Brisbane gynecologist. She's amazing. And she has a book on pelvic pain. And she was the first one to really, in so many words, say, I don't want to misquote her, but do these superficial lesions even mean anything? Or are they just normal? Do women just have them and they come and go? You can ask her more about that. Again, I don't want to misquote her, but I think that's when I heard her talk about it and interviewed a few times. And I just started thinking, okay, yeah. So that's what I mean by, the mere presence of the lesions, it's like, may not mean very much, which is, it's disconcerting. Like it's troubling because it's going to require quite a back to the drawing board approach for a lot of this, but yeah.
I've also been really fascinated with several different, I guess, companies and maybe governments, but people attempting to diagnose non-surgically. So through menstrual blood, through urine, blood tests, those kinds of things. And I know there's a lot of conversation in the endometriosis communities about it. And I just keep saying, look, I want everyone to do it. Like everyone throw their hat in the ring and hopefully we'll come out with something that really works diagnostically that's available for everybody.
Sure. And then again, the next question is, though, how do you treat that? Again, the paradigm that shifts that's happening is really a lot of different experts, like different reasons moving away from the surgical paradigm.
I bet you see the numbers, because if it's 1 in 10 now, but you have to have surgery to get the diagnosis, the numbers, I think, would just bloom, which would give more funding to the research on treatment.
Sure. Yeah. Yes. So I'll just say endo is of all the topics, there's lots of things in women's health that is tricky, like a landmine, like a landmine field, but endo is one of the ones. And so I've been trying to be careful how I've been talking about it here. Yeah, we'll regroup next year. We'll see where the research is at in 12 months and try to revisit it. But
all right, that sounds perfect.
Yeah.
Okay, I guess the next step is like, where can people find you and talk to us about your new book, where they can purchase it, anything new and exciting that you want to share before we do our lightning round fun.
Oh, I forgot about your lightning round. Anyway, I'll just say it's been great talking to you guys as always. I'm easy to find. Everything's at larabriden.com, and all my social media is at Lara Briden. I'm just very lucky there were no other Lara Bridens out there. So I got to have I've got 3 books: Period Repair Manual, Hormone Repair Manual, which is for perimenopause, and then Metabolism Repair for women. Yeah.
Love them. All excellent books. Get the trilogy.
Yeah. They're great. I love them.
All right. We have new rapid
okay.
for you. So we revamped at the beginning of the year. So you get new ones.
Okay.
But not your book, but what's your favorite book?
I'm a fiction reader. I'm actually just, my mom and I'm staying at my mom's place right now. It's my parents' place. I'm rereading some 19th century literature with her by Anthony Trollope. So that's a very obscure thing. But I'll just say another book I want to give a plug to is a book by Oliver Burkeman called 4,000 Weeks. Have you guys seen that one? I have mentioned it in a few other podcasts. So we get if we live to 80, we get 4,000 weeks, which is not very much. And so he calls it time management for mortals. It's really about just being realistic. I remember he has this one exercise in the book is list the 10 things you want to accomplish still with the remainder of your life. And then list them in order of priority, and then chop out the bottom 7 because you're not going to do them. Like you have to pick the top 3. And I was like, it's just stuff like that. It's quite sobering, but also quite freeing in some ways. So.
Okay, I just wrote that down. I like that.
Mm-hmm.
Hey, what is one thing you cannot live without?
Walking. Yeah, I'm a avid walker, but challenging where I'm in Canada right now where it's minus 25. I'm going to go cross-country skiing instead. But yes, I walk to survive in lots of ways. Like it's just, my nervous system needs that.
Yeah, I get that. What's your favorite snack?
I'm going to say cashews just because I do. I think I had before it's morning here. So I had a handful of cashews before the interview. Just get me through the hour till I can have a proper, chicken soup breakfast. But yeah.
I love cashews too. That's like my morning on the run if I have to get the boys to school before I've had time to eat.
And again, they're not the highest protein and they're probably not perfect, but they taste good. And so I guess
I love cashews.
Yeah.
They're nice and crunchy and
Pistachios all the way.
Okay.
Oh, I like pistachios. I like all nuts, honestly.
Yeah.
What's your guilty pleasure?
I'm just so many. My brain is I guess I would have to say dark chocolate. I don't think it's that bad actually. But I'd say that's an addiction. Sometimes my husband are like, I think, because it's quite expensive in New Zealand. We could probably knock this off. We don't have to have a bar of dark chocolate every day between us, but yeah. Yeah.
If you could live anywhere in the world, price, housing availability, nothing matters. Just anywhere in the world, where would you live?
It would have to be New Zealand. And so that is what I've done because I'm Canadian. Never thought I would live overseas. I had to go to Australia and then New Zealand for my stepdaughter for kind of personal reasons, but she's all grown up now. So we could easily move back to Canada. And I'm just, very attached to New Zealand. It's just a beautiful,
there's nothing like it. It's so beautiful. And I just love when you drive and you don't see anyone for a long time. Like it's really amazing. Do you have a favorite season?
Autumn. Yeah, in both New Zealand and Canada. Yeah, I do like it when the days start to cool down and the skies are bright and colors are.
Yeah. Most loved and most hated food.
Oh, Okay, most hated I can say. I really don't like meringue, or what would you call it? There's a few desserts in New Zealand that use it. It's like the egg white with sugar, and it's not from a health perspective, although I think that sugar is bad, but I just really don't understand how that's a popular food. Well, the thing that pops into my mind is the slow roasted duck legs that my husband makes sometimes. So, yeah, with roast potatoes. So that kind of, that's probably one of my favorites.
Yummy.
Yeah.
Favorite movie?
Oh God, you guys have a lot. This is.
We're gonna get to know you.
Yeah. I don't know. The thing that came to mind is New Zealand related. It's going back 20 years now, but I did love The Lord of the Rings. I was a fantasy geek when I was younger. I think that was a pivotal moment in my life when those from 20 years ago, Lord of the Rings films came out. So I'll go with that. Yeah.
I just stitched the "Not all who wander are lost" cross stitch from Lord of the Rings, from Tolkien quote. But yeah, I absolute nerd right here.
Yeah.
Do you have a hobby, like totally unrelated to anything out in the world, but a little just personal hobby?
I know these are really great. Okay, yes, the one that comes to mind is I'm an avid bridge player, which I know is weird because it's like we think they're like an old person. I am an old person, so maybe that's why. But we grew up as kids playing. My parents play bridge. We learned bridge, so contract bridge, which takes a year to learn.
Oh wow!
My husband learned it. It was part of his marriage vows. No, I'm just kidding. But he actually learned to play. Yeah. So if I get a chance, I could play bridge all day. Yeah.
Euchre. That's another old person card game that I adore.
Yeah.
Never played either. I need to look into this. Okay. Best concert you've ever been to?
It would be Radiohead 20 years ago. And then I'll just follow it up. I just got to see Tom York. Came to Christchurch, New Zealand, where I live. About 4 months ago, we went to see that. And I'm like, because I'm an old person, I don't go out at night very much. But I was like, my husband's, oh my goodness, you're going out to a concert. You went to a concert hall, and it was great. And yeah, there were all the Gen Xers in the audience and some young people. It was interesting. They were like a bunch of people my age, which makes sense with Radiohead. And then there were like some very cool looking Gen Zs. I'm like, oh, there. Yeah.
Nice.
Last question. Okay. What's your ideal weekend?
Like a full-on like multi-day walking and then sleeping in a hut or a tent and walking again the next day. Yeah. In New Zealand or Canada or Greenland. I went to Greenland a year and a half ago, and we did a 12-day. It's more than a weekend, but we did a 12-day walking trek there. So that was life-changing to a large degree. Yeah.
That'd be amazing. I know the Swiss Alps have those chalets as well that you can. Yeah. Oh, that sounds amazing. I'm in. Let's do it.
Yeah.
Thank you so much for joining us today. Thank you for dispelling all of your wisdom and talking about the book. Everyone go buy the books, all of them, if you don't have any of them. And thank you for indulging me in my own personal side quest there at the end. I really appreciate it.
Thanks for the questions. That's fun. I was nervous, but got through them. Have to.
No, it was great. It was great. And it really is such an important conversation for women, again, because all of it's related to our heart health, our brain health, all of those things that are so skewed towards women. So I really appreciate you coming and sharing all of this wisdom with us, since it's such a huge topic for women. I really appreciate it. Thank you so much.
Yeah,
Thank you.
Thanks to everyone for listening, and we will see everybody in our next episode. Bye for now. A big shout out and thank you to our sponsors for today's episode, Period Coaching School and Katie Bresek Wellness.
Thanks to you, our favorite bestie, for listening to the Period Besties podcast, where no topic is TMI. And of course, share this episode with your besties.
Remember to leave us a 5-star review, nothing less than the best for us besties. And subscribe wherever you listen to podcasts.
You can follow us on Instagram at Stasha Washburn and at Katie Bresek, or email us at periodbestiespodcast@gmail.com.
Check out more about us at katiebresek.com and periodcoachingschool.com. And of course, check the show notes for free goodies and extras that support this episode.
We'll see you on the next episode.
Bye for now, besties.